Climate change, traumatic injury, and obesity. What do these three things have in common? Dr. Ian Roberts, physician and professor of epidemiology at the London School of Hygiene and Tropical Medicine in the UK, joined us this week to talk about his fascinating research that appears to link this triad. We chat about his book, The Energy Glut, which ties climate change and obesity together, and through these we find our way towards his crash trials that were monumental in studying the use of tranexamic acid to help prevent hemorrhaging out in trauma patients. His recently published study, TraumaINTACT, showed very promising results about intramuscular TXA, which would be a huge step towards potential pre-hospital time-saving hemorrhage treatments, and he also tells us about what he has planned next. Enjoy! How are you?
I'm very well. Nice to see you.
Thought I was so excited to get to talk to you because you have, like, I was looking about you. First, I saw your trauma study, which we will get to. And then the more I looked at you, you also have this like interesting triad almost of interest of like obesity, climate change, and trauma.
Yeah.
And which I really, first, we're going to talk about how this all links together because that I couldn't figure out at first. But as I got into it, I thought I resonated with it so much because A, I'm doing my master's and I'm working at the hospital in trauma research. B, I did my undergraduate thesis on climate change. And then I'm also varsity rower. So there's these three things. And I was like, I need to talk to him. I need to, yeah.
Right.
So that was my excitement, my selfish excitement to get you onto this.
Well, we better get cracking then.
Yep. So first, I guess we'll start with, so what came first in terms of chicken or the egg, trauma or the sort of sustainability side of things?
So trauma came first. In fact, a long time ago, I trained as a pediatrician, and then I was working as a pediatrician in a hospital in New Zealand, and I got very interested in pediatric trauma, and I was rather horrified by it. And then I thought, well, look, treatment isn't the answer here. Prevention is the radical approach. And then I started training in epidemiology and working in injury prevention. And I mean, you don't have to be it's an energy disease, Haddon, the Haddon matrix, injury is all about energy. And you just think, well, that's kinetic energy. Kinetic energy did that to that child. Where did that kinetic energy come from? Well, it came from burning the chemical energy from oil in that vehicle. And then you think, well, okay, burning that oil within that vehicle causes more problems than just the one I'm seeing today. It seriously injured or killed this particular child, but it also it's made the air, it's polluted the air. It's made our streets dangerous so that people don't want to walk and cycle, and those are good for health. And it's putting carbon dioxide in the atmosphere. So it's almost like I started with trauma and then followed the energy back to oil, and then you follow the effects of that energy off in different directions, and then you see whoops, my phone's going. Everything's related to everything else.
Yeah. Okay. So I have so many questions to ask about both, but while we're on the topic then of the climate change and obesity, so you wrote a book in 2010, and that was the Energy Glut. So it's about climate change and obesity. So I mean, in the past 10 years, I'm sure we've gone even further in this distribution of obesity. Do you have any ideas how this sort of epidemic can stop if we're still, I mean, transportation's not really going to stop anytime soon. We're not going to get rid of cars. We're not going to get rid of planes. How do you sort of turn that around?
I think we will get rid of cars. I think cars are really outdated technology. They are, I think in towns and cities, they don't really work very well. If everybody wants to get around in a car, it doesn't work. It just causes lots of problems. It causes urban air pollution, congestion, road danger. So I think we'll have to demotorize our towns and cities, and that will have. I mean, there could be, some electric vehicles for people who have mobility issues, or you have to get food into cities. So generally, early in the morning in major cities, you have all of these big diesel trucks bringing all the food into the city. So I think maybe we'll have some vehicles in cities, but going to the shops and going to work, not car isn't the answer really.
And so is that what you meant? Sorry, is that what you meant by carbon rationing then as a solution? Like getting rid of these motorized vehicles and...
Yeah, carbon rationing was proposed as one solution. We've all got certain, there's only so much of the atmosphere left. And if we all had my phone keeps on going off. If we all had a piece of it, fairly we'd think, well, if I've got a carbon ration, do I want to spend it? Do I want to spend it in my car, or do I, want to do something, find a more constructive way to use it? Or, I mean, not use it at all, because ultimately we've just got to stop burning fossil fuels. There's no two ways about it.
Yeah. So climate change caused by lack of sustainability and fossil fuel burning then leads to more cars on the road, leads to trauma. That's how this all circles about.
Well, yeah, it's like burning fossil fuels causes road danger, and road danger, people get into cars because they think the roads are dangerous, and it leads to a nasty, vicious cycle. So we've got to wind our way back out of this, and we've got to decarbonize the whole of society. I mean, that's obvious,
Yeah.
We have to just get fossil fuels out of our lives.
Yeah.
Yeah.
I mean, I guess hopefully promising that with the new diets coming about, and there's veganism, vegetarian, they're trying to minimize that. At least there's a step in that direction. But I think on the flip side of the coin, obesity is still getting so much worse that I don't know how much just that will help.
Yeah, I
that
think
will take some.
the thing about obesity, it's not, which I've tried to get across in the book, it's not like a personal failing. It's always, it's an environmental issue, right? So the reason that people, the reason that the whole population distribution of body mass index has shifted upwards is that everybody lives in a strange obesogenic environment. We've taken all human movement has been replaced by fossil fuels, so we don't let people use energy to move. So they use fossil fuels to move rather than food energy to move, and then we've taken all and then our food is very energy dense. It's like fat. We eat a lot of fat and sugar, and so it's just you have to be completely weird to be thin. In this society, it's normal to be fat.
And people almost look at you weird, thinking, "Are you not eating enough?" And it's almost a weird judgment in that side. And I actually watched a video that was posted of you giving a talk, and I found it so funny when you mentioned how bizarre it is. Say at an airport or whatnot, they have the what do you call it? Like not an escalator, because there's no steps.
Yeah, they're travelators or something. They're
and that it truly warns you you're gonna have to move in a second. Like beware, watch out.
Right. Yeah, and so we've got to put the human movement back into society.
And then was it during, I think I read you were writing this book while you were working on some of the crash trials, correct?
Yeah, we were doing the crash trial. Took a bit of time. We randomized 20,000 bleeding trauma patients, and while I was doing that, I was just thinking about all of these energy issues and wrote The Energy Glut, which isn't a bestseller. I mean, if you've read it, you're one of a small elite group of people in the
We're
world.
getting it out there now.
I don't think so. I don't think it'll ever be
No,
a
but it was very
bestseller.
interesting.
Oh, good. That's very kind of you to say that. I think it's always a problem when you know all your readers personally. You know, when you've met them all.
Um, darn it, I
Oh,
shouldn't have invited you. Then we wouldn't have met, and I could be
you could
the
be the
one
one
unknown
reader I
reader.
don't know. Yeah.
And then so the crash trials, there was a few of them, but one of them was pretty big because it showed that corticosteroids, which were being used for head injury management, were not actually improving outcomes, but were increasing death. So that was pretty big.
Yeah, that was the first crash trial we did. Corticosteroids in traumatic brain injury, hoping that it would improve outcome, and it didn't have the opposite effect. There was an increased risk of death with corticosteroids. So that was a bit of a blow, but that taught us how to do big trials. And then our
Yeah.
next big trial was the Crash 2 trial of
And that was the
tranexamic acid.
TXA. Yeah.
Tranexamic acid in bleeding trauma patients. So we just got a lovely result for that one. We got a
Mhm.
highly significant reduction in the risk of bleeding to death.
Yeah. And
Yeah.
that one led to TraumaINTACT, which was, I was so excited to see those results because about a month ago, say in my master's, we have an intervention study. We have to think of some sort of RCT and come up with subject, write a protocol. And I was actually going to do comparing intramuscular TXA. And I ended up not doing it. But then I saw this study and I was like, oh my gosh, I was on it, knew it.
Yeah.
But I was so excited to see that there was positive results coming out of that.
Yeah. I mean, obviously, it was a kind of technical paper, really. Like the main results are from the Crash 2 and the Crash 3 trials, which
Yep.
show that tranexamic acid is life-saving in extracranial and intracranial injury.
Mm-hmm.
But it has to be given really quickly. So it has to be given ideally at the scene. Now, in high-income countries, paramedics can put an intravenous line in and give tranexamic acid. But in a lot of low and middle-income countries, paramedics, or there aren't any paramedics. They're sort of ambulance technicians. They often don't have much training at all, and
Yep.
they can't put an intravenous line in. But lots of people can give an intramuscular injection, and especially, you can imagine a pre-filled syringe or a auto-injector device, and then it could be really easy.
Almost like an EpiPen.
Yeah, like an EpiPen for tranexamic acid, and there are companies around the world that are inventing that now.
And I think there has been some use of it in, say, war zones. So it's, I guess, more based on the theory now and use of it because they can't set up an IV when you're out there.
Yeah. So the army are very interested in developing a tranexamic acid injector for use on the battlefield. Yeah.
And I
Yeah.
think, yeah, which would be great for pre-hospital. Are you looking now to move more continuing on the trauma route or more in, say, the system? Like, what are your current projects, if you don't mind me asking, or future
Okay.
directions with it?
So tranexamic acid in trauma, we're planning a new trial called Crash 4, not surprisingly, after Crash 3. And what we're interested in is older adults with so-called mild head injury. So a lot of trauma now is older adults with a fall from standing height,
Yeah.
and they get what's called minor head injury. A head injury with a bit of loss of consciousness, a bit of grogginess, and then they kind of recover.
Mm-hmm.
And their GCS is not, profoundly low, but it might be, higher than 13.
Yeah.
And those people go through a period of risk. They're at risk for intracranial bleeding. So older people are at higher risk for intracranial bleeding, and for various reasons, anatomical reasons, but also they're more likely to be on blood thinning agents. And what we want to know is if the ambulance arrives and gives an intramuscular injection of tranexamic acid at the scene of
Yep.
the injury, will that reduce their risk of bad outcomes? And we're starting the Crash 4 trial in a couple of months, I hope.
That's really cool. That's really interesting. That's that. I like how you've gone from pediatrics all the way up to now the elderly population and going
Well,
from
it's just much harder to do things in children. One,
yeah,
there's less of them compared to adults, and the consent issues are more complicated, and then the
yeah,
dose issues are more complicated, because if you do a randomized trial in adults, you can use the same dose for everybody, and that's very convenient. Whereas children, you
yeah.
have to think about their body mass, or their body surface area actually, and then titrate and then change the dose accordingly.
Yeah, and now I'm curious about this. So there's a lot of talk now about, say, intramuscular TXA used in pre-hospital settings. How do you think that, if, because sometimes say if there's a blunt trauma, it may not be as obvious whether they're potentially at risk for hemorrhaging out compared to a penetrating trauma. Even the amount of blood may not actually be a good estimate of how much they're bleeding out. Are you sort of thinking it could be like everyone, if it's a high risk injury, gets it, or how would you sort of navigate who gets it?
Well, that's the problem with tranexamic acid at the moment, because it's primarily being used in patients with very severe injuries,
Yeah,
and um, and what and it has to be given early. So really, what we need is, it needs to be given early to a much wider range of patients. So you've got to give it to the patients who are bleeding before you really know that they're bleeding.
yeah,
Patients who you suspect could have bleeding, and then you're going to get it in really early. But if you only use it once you've got obvious problems, you're going to be using it too late.
yeah,
So there are two things that need to happen. One, it needs to be given earlier, and two, it needs to be given to a sort of slightly lower risk population. They seem lower risk. They've got normal physiology. So say you had a driver in a high-speed car crash. So that's a very nasty, dangerous mechanism. But when you
yes,
look at the patient, their blood pressure and pulse are normal. Well, they've had a high-speed car crash. There are certain, if they could easily be bleeding and you not know about
yes,
it.
yeah.
And so you should give it to them. And similarly, an older person with a fall downstairs, they might have normal physiology, but if they've got any abnormality in their physiology, they should be treated. So you should have a much lower suspicion. And the reason is, it's a very safe drug. We've randomized now like tens of thousands of patients, and we haven't
Mhm.
found any increase in the risk of side effects due to tranexamic acid. So
So if they weren't actually hemorrhaging or internally bleeding, they wouldn't have negative effects of getting that dose.
no, in fact, the most popular use of tranexamic acid in the world is in Asia, where it's widely used for skin whitening. Would you believe it? So,
Oh,
lots of Japanese women will take 75 milligrams every day of their life to lighten their skin. Um, and
wow.
I mean, it's just like surgeons use it, and surgeons use it before operations. There've been thousands of randomized trials, or well, hundreds of randomized trials, thousands of patients, no
Yeah,
increase in vascular occlusive events. So, if you've got, a safe drug,
yeah.
you don't need to ration it to those who, you know, the most desperately ill. You can actually treat early a much wider range of patients, and then there'll be more benefit. I mean,
It almost doesn't make sense why it's not being used more then, because I know even here there is some reviews, and looking at who was given it versus who wasn't given it, it wasn't clear cut. There were patients who needed it who weren't getting it, patients who were like, you'd think it'd be so much more widely distributed.
yeah. I mean, there's some really good things about tranexamic acid. It's cheap, it's heat stable,
Mhm.
it's generic, but there's some disadvantages of being generic, in that, no pharmaceutical company makes much money out of it. And actually,
Yeah.
the thing that pharmaceutical companies really do well, because then, they say they're good at invention, but actually a lot of drugs are invented in universities, not drug companies. But pharmaceutical companies are really good at marketing. So if they find if they've got a patented drug, they'll spend millions, billions sometimes marketing it, whereas nobody's promoting tranexamic acid. Nobody's getting slots at conferences and hiring key opinion leaders to write editorials about it. So that's one of its advantages. It's being cheap and generic is also its disadvantage.
Yeah, as with a lot of things, go where the money is. Sometimes the best solutions are not there. So, okay, well, amazing. I'm so glad I got to ask you about that. I don't want to keep you. I know you got to go. So I'm going to wrap
I'm looking at
there.
the time. I've got to go and pick up my twins from after school club.
Yeah. Go ahead. Thank you so much for coming on. That was very interesting, and I really, really appreciate it.
All right. Best of luck with your podcast. Nice to talk to you.
Thank you so much.
Take care.
Thanks for tuning in, everyone. I hope you enjoyed that conversation as much as I did. Dr. Roberts has truly discovered such a fascinating link between three of our world's biggest problems. If you like this episode, please comment, like, subscribe, and follow us on all our socials. You can find us at Behind the Numbers with no E in numbers on Instagram and Twitter, and keep streaming our episodes on your favorite platform. Now get out and move, and I can't wait to have you all tune in next week.